thank you for having this little interview. And I would like you to introduce yourself, if it's okay.
Sure. I'm Ed Craighead, and I'm the Vice Chair of Child, Adolescent, and Young Adult Psychiatry at Emory University, and I hold the J. Rex Fuqua Endowed Chair. I run a program with about maybe 800 or 900 outpatients per year and have an active research program.
I would like to know nowadays in your area and what you're doing, research and clinician work, what would be the main interest or the hotspot that you are doing right now?
Okay, well, I think there are two things that I'm particularly interested in and am active in research and publishing. The first is the prevention of depression among children who are at risk, and we've completed a few projects where we use a cognitive behavioral model. We've written a manual for the teachers and the students, and we've applied that in Iceland and Portugal, and we're able to replicate it with an odds ratio of about 7 to 1, meaning that for every one person who's at risk, who's in the program that has a depression, there are 7 times as many people in the control group. And we're just moving that now to begin work in Sweden and in Greece. So that's one aspect that I think is really important, because if you can intervene with people and keep them from having the first episode, then they're able to develop both physically and socially and academically and have a better chance then of avoiding the first episode, although no one has really long-term data about preventing the first episode.
Fantastic.
Yeah. I think the other main area of research is trying to come to a better understanding of what are the processes and mechanisms that underlie the successful treatment of depression. And for the last 6 or 7 years, I've been working with Professors Dunlop and Mayberg on evaluation of, with both PET scans and fMRI, identifying people who respond differentially to CBT and to medication. And we've been able to succeed. Of course, it has to be replicated, but in identifying some patterns of neural connectivity that predict who will respond to CBT but will not respond to meds at all, even though they're just as seriously depressed, and vice versa. So I think the field is moving very much in that direction, and probably will occupy the next decade as we try to get a better understanding of what are the targets of change in therapy and what are the mechanisms, even if it's cognitive. For example, from the top down, the intervention is clearly cognitive. At some level, it's having an effect in terms of brain functioning and brain connectivity, and it's understanding those different processes for each of the different disorders. And in fact, there are probably only a portion of the disorders that will have that particular pattern, and that's where we hope to clarify DSM type classification.
In your idea or your wish, where do you think that these 2 points are going to be 10 years from now, if you would?
I think that we probably are going to make a lot of progress, so that as we understand these mechanisms in laboratory research and with imaging and so forth, that we will identify associated markers that are easier to collect and where the clinician might collect them. A good example would be, for example, we believe that there is a set of genetic scores, a polygenic score, that relates to the pattern of neural connectivity that we have. And it would be much easier through the collection of either a blood sample or even possibly saliva, and then be able to identify who might best respond to which treatment. Because right now we're only getting about 35–40% of depressed people remitted, whereas if you match the people who were matched to the treatment that has that brain type, we have about 70% remission. A little less well with medications, but about 70% with CBT. Equally importantly is that we have a really strong predictability of who will not remit, with 90%. success in saying who will not respond to CBT. And that's just as important, because going through 12, 16 weeks of therapy and not getting better is actually very demoralizing and in my opinion, actually hurts the patient. So it's equally important to know who will respond, but also who will not respond. So I think where we'll be in 10 years maybe is having some clinically useful, practicable, everyday lab tests that will provide information about who should get therapy, who should get meds, or new meds if they're developed.
Thank you very much for your time and congratulations for your wonderful work.
Yeah, thank you very much. Yeah.